Je vais essayer, ouais. Bon, ça commence à...
Je sais même plus comment on partage. Je sais même plus comment... Ah voilà, c'est bon.
Attends, c'est pas comme d'habitude.
Si on voit, we can see your, put it in diaporama.
You can see my slides?
Very small. Can you put a slideshow?
Slideshow. Non, attends, 2 secondes. Oh là là. Ah! C'est bon là?
Voilà, c'est bon.
Okay. This is a story of a unusual cyst. It is a young female, 21-year-old. In December 2020, she experimented an epigastric pain without fever or other sign, and she went to the emergency room. There was a palpable abdominal mass in the right hypochondrium. Otherwise, everything was normal. The liver test, the lipasmia, no hyperleukocytosis, and the CRP was normal. And in ultrasound, we saw a huge extraperitoneal mass of liquid. So MRI was scheduled, and this is the MRI. Here. This is the huge cyst, not vascularized, thin wall. And this is the T2 sequences.
She had acute abdominal pain, right?
Yes. As you see, white in the T2. This is indeed a liquid mass. Okay? So what is your diagnosis? An hepatic cyst, a pancreatic cyst, a lymphangioma, a mesenchymal cyst, or other?
Okay, who wants to talk? Nobody wants to talk.
Do you want me to?
John Isaac. John.
I just have I'm not going to hazard a diagnosis right now, but it's interesting to see the relation of the cyst to the vena cava. It seems to be pushing the vena cava downwards and not upwards and to the left, which would be the case if it was adrenal or renal. So pushing down onto the liver, onto the cava from the liver, I would think probably I would think it'd be more likely hepatic in origin.
In hepatic?
Yeah, so just because of the relation to the cava.
Okay, another.
That's very interesting. So what you're saying is pushing down, so it comes from above, right?
That's right. So you have a renal or adrenal, it tends to pick the cava up and push it to the left and upwards. Yeah.
Yes, another idea.
That's very interesting interpretation. Let's look at the cava. Aha.
Uh-huh. Uh-huh. There is another sign to differentiate hepatic and, well, other origin mass. No? Nobody? Anyway, so I go on. In fact, it is indeed a pancreatic cyst, and you can see it because you can see the duodenum, which is completely around the cyst. Do you want me to go back to?
Yeah, go back, please, because we didn't have a really. Because
look at that.
Personally, I was looking at that, and I thought that it was outside of the duodenum. But now you're saying it's inside.
Inside. It is inside. As you see here, I don't know if you can see my arrow.
Yes, yes.
You can see? Okay. So this is the stomach. Okay. And you can see that the duodenum is here, 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 here.
Okay.
Okay. So.
I take your word for it. But
Excuse
it's
me?
difficult. I take your word for it, but it's difficult to see from here.
Believe me. Trust
I
me.
do, always.
Always. The decision, it was not in our center. It was to perform a function on ultrasound and a cyst fluid analysis. And this is the results. Cytopathology, it was an hematic sample, no sign of malignancy, no cells, in fact. And the markers in the fluid cyst was CAA 18, CA 99, 195, normal amylose, and a discrete increase of lipase. So the patient was symptomatic, with pain, and she couldn't eat very well, and it was in a certain diagnosis. So what would you suggest about this pancreatic cyst? I am listening.
Okay. Who wants to talk?
21-year-old.
John is.
Just a further investigation, Lawrence. I mean, just to see the relationship of the bile duct, pancreatic duct. Have you an MRCP to show us?
MRCP?
Mm.
Well, there was the MRI, and you can see that there was no consequences on the pancreatic or the bile ducts. No dilatation. Normal hepatic profile.
You don't have any other images to show, like coronal view or something, no?
A coronal view, well, doesn't help. Doesn't help. In fact,
I can see several. The first question is: Did you look for mucin inside the cyst?
well, as you know, it's difficult to detect mucin. Before, it was possible to analyze it, but now it is impossible.
The question is the type of cyst, whether it's a benign or malignant cyst or potentially malignant cyst.
Exactly.
If it's a potentially malignant cyst, you don't want to do a derivation or a you want to do
in fact, as you know, but I will repeat it later, the most interesting marker in the cyst is the CAA.
Yeah. Yeah, we know, but don't remember what you showed.
It is normal.
Normal, yeah.
On this function, it was normal. So I'm going.
May I ask a question, Laurence? Do you think that this value of the CA99 is pathologic?
It is not.
I think it's not. Normally, in let's say in malignant cyst, it is several thousand. So this figure of little more than 100, for me, is not pathologic.
He's talking about CEA because CA99 is always elevated.
Yes, in fact, I will say it later. But in fact, to differentiate serous from a mucinous cyst, the best marker is the CAA, and it is not really relevant for malignancy. In fact, it is important to detect mucinous. Mucinous, it's more than 200 CAA. So, in fact, this patient with this big cyst in the pancreas, in the head of the pancreas, was referred to a gastroenterologist, and they performed endoscopic ultrasound. And these are the results. It was a heterogeneous cyst, 10 centimeters of size, no calcification, no thick wall, and no mural vegetation. So they perform a second cyst analysis with all that. And as you see, the kilomicron was tested also. And so she underwent this investigation, and he decided to put a cystoduodenostomy, as you see here, to drain from the duodenum, what we think, to the cyst.
He decided this on his own without any discussion before?
Yes.
Because it makes sense. I think it's fine. I think I would probably propose that. But
why not?
Why not? But I think that this should be a discussion. But in any case, I think it's a reasonable thing to do.
In fact, we asked for a second function, but the first one was quite normal, and it could have been a lymphadenoma. So,
lymphangioma.
This is the procedure, and following the procedure happened two problems. The first problem is that she underwent a very acute pain after the exam, and this is the CT scan we performed just after, and you can see what happened. You can see here that the pancreas is strictly normal. You can see here the stents, and what you see is there is a pneumoperitoneum.
Yeah. It's difficult to see from our side because we can see gas in the colon and everything. So you're telling us there's a pneumoperitoneum, right?
Not a pneumoperitoneum.
Pneumo. So it's a pneumo. Oh.
As you see here, this is the portal phase. And you can see here that the stomach was full. Here you have the pancreas, no dilatation of the pancreatic ducts, but you can see here. And this is the cyst, which is quite big, and the stent. And here the wall is very thickened. Okay?
And where is the pneumoperitoneum?
I can show you again. This is only some...
There's bubbles, right?
Bubbles, yes. You can see here, one, and...
very simple.
It's just around the head of the pancreas.
Okay.
Okay, you can see here you have them bubbles, okay? So the second problem is when we received the markers in the cyst, completely different. The amylase was 148, lipase was 260, kilomicron 0, but CEA was 647. So we're quite anxious about the real nature of the cyst, and it appears to be a mucinous, and we are really quite concerned about the peritoneal dissemination. So what we can do now should be resected, and it was a Whipple procedure at 21-year-old. So what do you decide?
Jean-Robert, tu veux?
Oh, it's quite surprising. Yes, just a word. It's quite surprising that the first MRI, the wall of the cyst was very thin, very normal, without any alteration, and after the endoscopy, the morphology is completely changing.
Yes, you're right, and we didn't understand very well, but I think she bled into the cyst. And the CT scan you see was done the day after the procedure, so it was quite rapid after.
Yeah, but I mean, you expect it to be different after drainage anyway. And what you said is the first puncture, it was blood to start with, so it had bled before.
Yes, probably. The first puncture
probably the acute
completely
pain,
different.
The acute pain was bleeding. But
Yes. So, so she was quite painful. So we wait and we decided a surveillance with antibiotics and a nasogastric tube. She improved quite rapidly, and I decided surgery a week later with the diagnosis of mucinous cyst.
just
So,
because of CEA, right?
because of CEA, which is quite
Diagnostic, which is
relevant. So I performed a standard pylorus preserving Whipple procedure. When at the opening, no obvious peritoneal dissemination, but there was a huge inflammation of the cyst, and the drains were located not in the duodenum but in the antrum. So we removed the drains, and the holes were closed, and we performed a duodenogegenostomy, a bilioenteric anastomosis with thin biliary duct, and a pancreatogastrostomy with internal stent in the pancreatic duct, because, of course, she had a soft pancreas with a very thin versum. So she had an uneventful postoperative course, and she was discharged at day 11. So this is the pathology. It is indeed a mucinous cyst adenoma, but our pathologists were quite anxious about the real diagnosis. She said she was probable a mucinous cyst adenoma because there was no residual epithelial wall, but of course at the opening we had a quite mucinous content, and there is maybe some areas of ovarian stroma, but she was not completely sure of this diagnosis. Anyway, at day 21, of course by night, my resident on duty phoned to me. She just have been readmitted for a sudden abdominal pain with two vomiting episodes with blood. The hemodynamic was stable and the hemoglobin was 10. So, what is your diagnosis, Jean-Robert?
Let's go for CT first. CT scan.
This is the CT, of course. This is the arterial phase. And this is the portal phase. You see, we put a nasogastric tube, of course, not really efficient, as you say.
There's a collection of this gas here. Probably hematoma.
This is the joy of pancreatic surgery.
Yes.
In real life.
Okay, so
is there blood in the stomach?
Not very much. Really not a lot.
Well, she has a collection. She has a leak somewhere, and she needs to go back to the operating room.
Okay. The radiologist said there is not active bleeding. There is an hematoma here, of course. No active bleeding, but so what do you decide? Daniel, you already said that, but I'm interested in the fact of discussing that. Do you just surveil the patient? Do you perform an arteriography? Although there is not active bleeding on the CT scan with the embolization, eventually prophylactic, or I don't know, reoperation. So what do you decide?
I would take we didn't have to look at the scan, but did you see the gastroduodenal stump on the scan?
Right.
It is very, very difficult to see anything on this CT. I was looking at it more than 10 times to
I'm sure that the radiologist can do reconstructions, mid reconstruction, up and down, etc. So he couldn't see any extravasation, right?
Yes, you can see there is the hepatic artery, which is good, the splenic artery, and it is quite difficult to see the pancreatic stump. Maybe it's here, maybe here. It is very difficult, but surrounded of hematomas. So, as you said, Danielle, it is impossible to monitor only this patient. She had an hematoma, of course. 21-year-old, of course. So arteriography, no need, because we have to go there and there is no active bleeding. So I decided a reoperation several hours after, and these are the intraoperative findings. In fact, it was very difficult, those reoperation at day 21, as you all know, and we had to undo the duodenogenostomy to access to the hematoma. And in fact, it was not an intraperitoneal edema, but it was into the gastric wall and probably on the site of the previous drains, in fact, on the entrance. So there was no leakage of the pancreatic gastrostomy, and this is only this huge gastric submucosal hematoma. So we redo the duodenogenostomy, drain, and fortunately she was well after the second operation without any transfusion, and I saw good and was normal CT scan. So
any comments?
In conclusion, I think that the internal drainage was not really a good idea. And maybe I'm wondering if I decided a pylorus preserving procedure, which I do that when I do a WIPO on a very young patient. But it was probably not a good idea because the antrum was really not very beautiful when I operate. I closed the hole, which was because of the stents. And of course, the diagnosis also is really rare at this age. A mucinous cyst, I saw in the literature, is very, very rare. We could have evoked other diagnoses, like endometriosis cyst or lymphangioma. But anyway, as I said before, the fluid analysis is very informative in the literature and in the guidelines. The cutoff of 200 is in favor of a mucinous cyst with a good predictive positive value, and it is an indication for surgery if the cyst is more than 4 centimeters. Problem of this patient that she has a very large mucinous cyst, probably hemorrhagic, and we are not completely sure that is a benign one. Remember, there was a peritoneal dissemination. So what follow-up would you recommend for this patient?
Robert, John, you want?
Yeah, just a quick comment, Danielle and Lawrence. You know, often these cysts, MCN, they present exactly this way with the epithelium. And the epithelium is the malignant risk in these cysts, not the stroma. And very often the epithelium is denuded. You don't see epithelium because of inflammation or bleeding. So if you see it and there's dysplasia, yeah, you have an indication. But if you don't see anything, you're really in the dark here because it's gone. You don't know the malignant potential. It's hard to put the figure on the frequency, how often you want to surveil this patient. But obviously the size, the potential for dissemination she needs regular CT scanning, 8 months, yearly, something like that. But, the exact figure is difficult timing is difficult to pin down.
Yes, I agree with you. I had to surveil this patient. It's difficult to explain that it could be. I don't think so, but it could be malignant.
I think she would be okay. Jean-Robert, you want to?
No, you need Laurence, as you know, you need a long follow-up.
Okay.
Very long follow-up. And just for the discussion, why do you preserve the pillow?
Yes, same question.
Oh, this is a very interesting, because I had this with my colleagues. In fact, maybe it's wrong, but as you know, in the United States, pylorus preserving procedure is the standard, and there are a paper that said that the nutritive status is better with pylorus preserving. When I do Whipple for other indications, I have, well, let us say 5 to 10% of patients suffering from diarrhea for damping syndrome, and it's difficult to know who will have this type of complications. And the last and very important for me argument is that if you do a gastrectomy, you have to follow this gastrectomy, because there is, as you know, cancer on the gastric jejunostomy 20 years, 30 years after. So when you have a 21-year-old female, well, she would live a lot of time, and she had to be surveilled on this gastrojejunostomy. With duodenal jejunostomy, it's not worthy. So that is my. That is why I did that, but maybe I was wrong.
Okay, I have a question to the group.
Daniel, may I do a remark?
Sure.
Yeah, look, I come back on the first picture. When Laurent starts to show us the picture, the first idea we have when we look at this voluminous liquid mass inside the liver is this is a cyst of the liver. And what I would like to say is that any kind of tumor outside the liver may enter the liver. That means the image seems to be inside the liver. The difference between something extrahepatic and intrahepatic is the capsular glycerol. But the capsular glycerol we cannot see. And for instance, we observe a voluminous adrenal tumor. And when we have the CT, we have the feeling that the tumor is inside the liver, totally inside the liver, round.
Yeah.
But indeed, it was extra. The only difference is the capsular glycerol, that you cannot see. That means it is very difficult, and we are very careful. And this is exactly the case of Florence. I mean, the cyst appeared to be inside the liver. Indeed, it was not.
Okay, we need to move on. But I have a question, though. If it's so, you demonstrated it's a pancreatic cyst, and so isn't there an indication for resection of any large pancreatic cyst? Jean-Robert, John, or the others, pancreatic people?
Today, when for the mucinous cyst, less than 5 centimeters of diameter, we do a survey, no surgery. The cyst of Florence is it's a huge cyst. Now, the question could be, Laurence, is there any option of conservative surgery in this patient? Because the biliary tree is normal, the main pancreatic duct is normal.
In fact, after the drainage, it was completely impossible, because there was a stent through the cyst. It was very inflamed. But maybe at the beginning,
Yes.
it would have been possible, but as you see on the pathologic specimen, it was really within the pancreatic duct. So it was for me quite difficult to avoid the Whipple procedure anyway. With 10 centimeters, it was impossible. At the beginning, I thought when I saw the first image that it was a lymphedema of the pancreas. And maybe I was thinking of just a duodenal hysterostomy. But it would be quite preserving. But here, for a pancreatic cyst, it is impossible.
Maybe, Jean-Robert, you were mentioning a enucleation, for example?
For example, before the drainage, when you see the like Laurence said, and this is another argument not to drain before the discussion, because when you see the first image, the CT scan, you can say the biliary tree is normal, the main duct is not dilated. Perhaps I try.
And this is why the gastroenterologist should not do things without discussion.
Of course.
May I just make a short comment? I think we were all misled here because of the age. Right? She was 21, and then the first reflex, do nothing. Any other patient, large cyst, maybe any, I don't know, large cyst, symptomatic like this one, you want to get to know and be rid of the problem, or you go for a Whipple up front, whatever technique you go. After the ultrasound, I think the endoscopic ultrasound was very important, but if it confirms that, we don't know what that is. It's clearly not a pseudocyst, so it's symptomatic. I think we were just going on the wrong direction because she's 21 and we want to offer something better, and at the end we go to some disaster.
Well, she's recovered. Okay, we need to move on because we won't be able to continue. Pierre-Alain and your fellow wanted to present a case. You want to go ahead?
Well, thank you, Daniel. I mean, I would be very happy to case and hear the opinion. So this is Dr. Povilas. He's our second-year fellow from Lithuania, and he's finishing his fellowship. So I thought it's a great honor for him to present to this prestigious group this case for a discussion. So I let Povilas to present. It should be quite short.
Okay, thank you, everyone. Thank you for the opportunity to present this case, and thank you, Professor Clavien, for the introduction. So it's pretty short case.
Wait. Laurence, tu peux te relâcher parce que tu es toujours en présentation, Laurence. Voilà, arrête, stop presentation. And now, what's your name again?
Yeah, my name is Povilas.
Oh, I can see you now.
Yeah.
Povilas, can you share your screen, please?
Yeah, I'm now sharing the screen. Yes. So, can you see it?
Not yet. Yes, it's coming.
Are you seeing my screen?
We can see, yes, and put in slideshow, please.
It's coming.
Slideshow, please.
Yeah, I made it. It may take a few seconds. Is it okay now for you?
No, we have the PowerPoint, but we don't have it as whatever. We can see, but it's not slideshow for some reason.
Yep. All right, let's try one more time. Now should be a slideshow. Made it. So we have a patient of 57-year-old, a female patient, and we saw her 2 days ago in our outpatient clinic. She was admitted from her GP to us because of some lesion in the liver. Before she was not operated, she has no other disease, so she never saw a doctor, but since several weeks she has a pretty strong abdominal pain, and she says that the abdomen is getting bigger and she has some big abdomen distension. We looked at the lab, liver enzymes are normal, we have only slightly increased bilirubin, and something was already done by the GP. It was an ultrasound, it was also a CT scan, and we done an MRI. And I show you just in a minute 2 images from it, because we have a suspicion of a large hemangioma. Let's hope it will be working. Can you see the images?
No.
Just maybe
Yes.
it'll take a few seconds because of internet connection. Yeah, I tried to scroll it down. I hope it will be working. Do you see scrolling?
Yes.
Okay, so it's a CT scan. I talked with our radiologist which images are the best one, and I think this one. So it's really a large hemangioma, and actually it's at least 3 or 4 hemangiomas. And what's important to know is that when we look at the liver veins, we see only very small.
Povilas, don't say too much. Let's for the discussion.
Okay.
I will not tell them describe what that is. Just show the pictures, and now maybe the discussion where we go, what do we need to know in this liver for whatever options. I think.
Yeah. So I just show you the images. So we have this large liver. So I'm going down, and I can show you where touched all. So some other images of these.
Oh, there are more.
Exactly. So this is the images what we have. So what?
We have only this information from the CT. The diagnosis is not written. We don't have any biopsy. The liver tests are normal. How high was the bilirubin? Very slightly elevated.
Yeah, it was 25 micromolar.
Platelets are normal. And,
platelets are normal. Yeah.
The patient is pretty highly symptomatic.
Yeah, it's abdominal pain and distension, several weeks.
So, Daniel, you do the moderation?
Yeah, I do the moderation. So, anybody wants to talk? Well, I think diagnosis is Professor Bismuth.
Yes. As you know, the size of the angioma is not indication for treatment. But you said that there is pain in this patient. And at that time, I think there is indication for treatment. I think that for me, is accepted, the only treatment of angioma is surgery. And we may discuss other treatment like embolization, but in my experience, in the time, it was a failure, and the only treatment is surgery. Surgery, the basic surgery is enucleation. Even if the tumor is large, as the first step of the operation is to clamp the artery. Sometimes we have very difficult access to the artery. We have only to push the hand and to arrive to clip between the finger the artery, not to clip, to clamp the artery, and sometimes the vein, not the hepatic vein, the portal vein, but the artery is enough. And we make time, and we observe a very large decrease of the angioma. And then you may put the clamp, and then the surgery. I was surprised myself that even very giant, it was possible to do enucleation. So of course, here you have vein dilated all around the angioma. You are afraid of that, but the angioma never penetrates the vessel. The vessel are always outside, and there is a plane of cleavage around. So this is what I want to say at the beginning. It could be it is wrong, and I think Pierre Alain will say I am wrong. It was not that. But this
so we get to your point.
This is the basic attitude.
So your point is we have two others talking. So your point is, number one, this is a hemangioma for sure. Number two, it's symptomatic and it's huge, so there's an indication for surgery. There's no other treatment, and the surgery that you recommend is enucleation. It's first clamping of the hepatic artery and then enucleation.
Yes. But only one word. I say angioma for Pierre say it is an angioma. He announced angioma. So I think it is angioma if he said angioma. It is not remark. You announce angioma.
Well, this is a radiologic diagnosis. Okay? So at this point, the patient we have these pictures, we discuss with the radiologist, we will be able to expand with that, and our diagnosis will be an hemangioma, but we have no biopsy, we have no proof of it.
Of course, no biopsy.
But MRI,
yes,
the MRI is diagnostic. So
yes.
I don't think it's a diagnostic problem, personally. That's my take on it.
Yes, I agree.
Mm-hmm. So any other, I would be very concerned about doing enucleation of such a huge thing. So, and I'm sorry that Eduardo is not here, because I presented a case like that and he said, no problem, enucleation, it's very easy. What about the others?
Can I say something?
Sure.
Of course, enucleation is possible, but here, if I'm not wrong, it's not really an hemangioma. It's nearly several hemangioma, because you have the big one, and in the segment 7, in the posterior segment of the liver, you have also another hemangioma. So it's not just one hemangioma. And I see that I'm not able to see very well the hepatic veins. The hepatic veins, and particularly the right hepatic vein, is completely surrounded by the hemangiomas, and the left one is, well, I think enucleation here, for me, at most, is completely impossible.
So there's also bile duct dilatation, despite the fact that the enzymes are normal. But are you saying that maybe pain would be due to a sign of Budd-Chiari-like syndrome or something like that?
I don't think it's a benign tumor. It's not. I think that there is not Budd-Chiari. There is not enlarged liver. There is
okay. And enzymes are normal.
Ascites, but no, it's the mass which is painful, of course. But I was talking about resectability.
Okay.
May I say to Laurent? You know, if when you observe near the huge angioma another one, I think the objective of treatment is not to treat all the angioma, but to treat only the symptomatic angioma. It happened that, you know, in my experience, there was often near the big angioma, one or two smaller, but they are not symptomatic. Objective is to treat the symptomatic. That means it is not a contraindication when there is another one, contraindication to remove only one.
Yes, but your resection plane should not be trans hemangioma, because there on the segment of the liver you are surrounded by all hemangioma side by side.
No, I don't think so.
You don't?
Daniel, can I say something?
Sure.
Okay. I will say only one thing. I had the privilege, I would say, to have reviewed all the series of the hemangiomas in Paul-Brousse, and we are still working on it with Professor Bismuth, and he knows it. One thing that I can't see on this picture, I don't know where this largest hemangioma is, but in the series of Paul-Brousse, the largest one, which are the giant, hypergiant, as we called it, above 20 centimeters in diameter, very often they erase from that segment one. So they are the largest. So that's the first observation that I would say. If it is an hemangioma, and if it is symptomatic, indeed, and we did it in Paul-Brousse, if you look at all the series from the 1970s, all the hemangioma from the segment 1, which are above the 30 centimeter diameter, were successfully enucleated under total vascular exclusion. It is possible, and you have a very clear cleavage plane to dissect it with no parenchyma of the liver. So you can do that with success, with no problem.
Okay.
The only point that I want to say, I agree with you. We have to do an MRI. You have to be sure it is a simple, large hemangioma, which I differ from what we call the disease of hemangiomatosis, which is a different disease and has nothing to do with it. So first step, I would do an MRI because I want to see it properly.
Here it is. Okay. Now let's other people talk. Well, anybody wants to talk? Because I want to make a comment, but I don't want to take anybody's place. Okay. So I had a case like this that I presented a few years ago to the Compagnons, and I was in a fight with Eduardo because he says all hemangiomas can be enucleated, and personally, I would not even try to enucleate this one because it's theoretically possible. No, I don't think it's in segment 1. This one, by the way, but let's look at it. I think it's central. And it dilates, I think it's a central 458. In my opinion, it's 458. But anyway, whatever place it is, it's huge. And of course, when you clamp the hepatic artery, you may observe a shrinkage, but not always. And I think it's a dangerous operation. And we had a case like that. And what we proposed was to go ahead with resection, but with a liver graft available. And it was not possible to organize. So at the end, eventually the patient was transplanted. So, and I got a lot of criticism from Eduardo because he said you should never transplant a hemangioma. So at Paul Bruce, after you did your case, your study, there have been actually, I think the whole series of Paul Bruce, there are 2 liver transplantations for giant hemangioma.
Yeah.
There are 2 of them.
Daniel, I'm sorry, but I have to interrupt this discussion. I'm sorry because this is a subject that I'm really fond of it. Two objections of what you said. First of all, and I will agree that Professor Bismuth will correct me if I'm wrong. 2 things. When Professor Bismuth said you clamp the artery, is to say where the hemangioma is. But when you operate, when you do the enucleation, you shouldn't clamp the artery because you don't have a cleavage plan where you can do the enucleation. That's my first observation. The second one, I agree with you, very often the giant one, the hypergiant one, are the central of the liver. They are 4, 5, 8, and 1. Very often they are 1. To do a transplantation, if you look at the series, we did 3 transplantations for hemangioma and hemangiomatosis, I would say, because they were linked with the Kasabach-Merritt syndrome, and that's when you do the transplantation. But in that case, it depends if they are symptomatic. In the series of Paul Bruce, you have to understand that the hemangioma that are above the 30 centimeter of diameter, they were never treated. Never. They were followed up for 20 years and they never needed any operation as long as you proved it was a hemangioma. The simplest one that you have to operate, you have to do the enucleation.
Gina, please.
Oui, Daniel.
Okay. But please. Okay, we got your point.
No, only to conclude, what say Gina, in the series of Paul Bruce, and it is true, we work on what we call the extra giant, more than 20 centimeters.
Exactly.
We have 2 transplantations, but in these 2 cases, it was Budd-Chiari syndrome. Only that. So it's only that. Gina give the experience. Okay. Now, Gina, you stop and we let the other one speak.
Professor Bismuth, but this one, let's come back to this case.
Yeah, let's move.
It is a central one. There is involving the 3 hepatic veins. This is central in the portal triad. So for me, it is unresectable.
Yep. It's gonna be a death on the table. So
I think so. So for me, I agree with Danielle. It is an indication for transplantation if she's symptomatic.
She's highly symptomatic. Pierre, do you want to comment, please?
Well, number one, thank you very, very much. I always enjoy the fire in the belly for Gina. This is nice to hear that and to see that we have the passion for surgery, sometimes too much, because this case is not operated yet. And we had a discussion in our multidisciplinary with different conversation, which pretty match what's going on here. And where I was at the end of the bit where Daniel is, I thought, I don't know, Povilas, if you can show, segment 6 and 7 are pretty well preserved. Maybe the sagittal,
Yep.
You can just see that. We can see pretty well the posterior branch of the right portal vein, which is in contact with the tumors. And we can see the left hepatic vein, which is whatever in case, etc. On this situation. So my thought was to go for an attempt at resection, total vascular exclusion, so clamping. I mean, number one, I think we all agree, because it came also an MDT and a fight, as mentioned Professor Bismuth, for embolization. Some people come and say we embolize. I think it's the last thing to do. And what do we want to treat? We will not treat the symptoms, and if surgery comes, it will make it much more complicated, plus complications. So I think here, what I understand, nobody came with the idea of embolizing, wait and see what's going on. So the question is really, when doing nothing is also not fair. This patient is highly symptomatic. So it's transplant versus resection, or resection as a bridge to transplant. So come back. First, we have a living donor maybe available, and to go and to do total vascular exclusion. The danger is to take to injure the hepatic vein or the portal vein and end up to a liver failure. I don't know if I would call enucleation, but do total vascular exclusion and really stay away and remove everything else so basically keep only segment 6 and 7. This is most where the liver is. There is no other liver tissue. I think the risk of liver failure is low. We will do the test. We've not done yet in terms of HIDA and other things. That was the idea. 2 other members same expense as here suggest to go for transplant. And at the end, I say, well, there is a great group, a great opportunity to present this and to have a clear where we go. That's why we presented. So the case is not operated. I'm planning to talk with the patient on Monday, next Monday, probably to discuss. The patient cannot choose, but it's maybe good to explain a bit and see the patient may help us in this. But I was pretty ready to go. When I hear now that 2 say deaths on the table, I become a little bit worried, because I don't remember from a long time having any deaths on the table. I thought the risk is not, I mean, it's a big surgery. You need to be done certainly in a place when kind of fancy surgery. Mortality certainly exists, but when I come with a clear death on the table, am I a little bit scared of doing a...
No, I mentioned that, and I would like to just... I think that, in my opinion, enucleation is very dangerous. And if there's something to be done, it would be a formal extended left hepatectomy.
Mm-hmm.
But you still have an hemangioma in segment 7, which will remain. That's okay.
Yeah, it's okay.
I would like to see the right hepatic vein.
We see it. So we were looking at that.
So if you have right hepatic vein, you can do an extended left hepatectomy, which would be segments 1, 2, 3, 4, 5, and 8.
Yeah, we will.
You may have a problem with the bile duct, because you can see that the posterior bile duct is dilated, and you may have a problem there. So it's I would say that it's a risky.
Yeah, it is.
If you enter, maybe there's a cleavage plan between the hepatic veins and the tumor, but I've been there, and if you go into bleeding in such hemangiomas, you may not be able to do hemostasis. So I think it would be a formal hepatectomy, in my opinion.
Okay. Daniel, you listen to me?
Yes.
I am sorry to say, but for the first time, I think I disagree with you.
I know you disagree.
But I disagree really totally with you. For me, there is, of course, no indication of transplantation, no indication of formal anatomic resection, but enucleation. And here, when you start the total vascular exclusion, I think that you will see the change of the angioma. I have a movie, unfortunately, a giant hemangioma, and but you have to wait, not immediately, it could be 20 minutes, and then you see the change of the angioma, and the angioma giant. You may take it like this, like a beret basque. It was like a beret basque, you may move like
Exactement.
this. And let me tell you, I think, to conclude what I said, in this case, liver transplantation is a failure of liver surgery.
Okay, one thing though, if you clamp the cava, the hemangioma will not empty, okay?
I would add one thing. Sorry,
No, I think
Daniel, I know that you disagree with me, but I can give you even the name.
I just maybe ask for Povilas, the fellow, welcome to this group of very famous surgeons. And we basically at the end of our conversation. But since I'm sharing the opinion with Professor Bismuth, maybe I have a bias going into this. And maybe, Daniel, I call you if I have problem interruptively to come to help me to get out of this problem.
Every time for Povias, hemangiomas is always the same. Every time we discuss a hemangioma, it's a big discussion. So that's fine. Do enucleation.
All right. Maybe we will give you a feedback on that in the future.
Oh, definitely.
Thank you.
Thank you.
Sorry, there is Jean-Robert, and I would love to hear the opinion of Jean-Robert and Surendra, if I may.
No, I just want to ask everybody whether you will consider an ex situ resection, because what Daniel said, on table severe hemorrhage and losing the patient out. Instead of that, will you like to do a ex situ resection and then reimplant the screw with reconstruction? Will you consider that?
On my side, not. I mean, I think here the dissection, the vein and all that is difficult. I think I will go in situ. I don't know. I mean, that would not be for me a good indication for either. We can do intraoperative cooling, that we cool maybe, but the ex situ resection, that I would not go.
Robert? Ton micro, mets ton micro.
I just see in my life a huge enucleation by Eduardo Barroso when I am in Lisbona for teaching pancreatic surgery, and I am very impressed because the hemangioma is so huge for me, and it does an enucleation. So I am not an expert and I have no opinion, but just a comment. Why you don't give to the patient beta blocker waiting for surgery? Because in the children, huge hemangioma, very huge hemangioma, quite disappear with treatment with beta blocker. It's a fantastic paper in the New England Journal of Medicine recently published. No, it's just a question.
Does it work on giant hemangioma or not?
Okay, we need to move on because we have 4 more cases, and so I think we need to move on. So please, Pierre, follow up on this case. We need to.
I will. Thank you very much, and thanks to Povilas.
Thank you.
Thank you, Povilas. And you can come back and see a normal. Stay. There are going to be normal discussions now. So I think that we have 2 cases of liver metastases, one from me and one from Catherine Tay. Catherine is here, I think. And a case I think is unsolved, and mine is already operated. So maybe we can discuss mine. And I will start now if it's okay with you. So I'm trying to. trying to. No, I can't find it. I'm sorry. I'm going to open it now. I think Zoom is more practical, but that's all right. I'm going to open the case now, and hopefully. No. For some reason, I can't do it. Okay, I think I have it now. Let me know if you can see my slides. Can you see my slides? Can you see my slides?
Yes.
Yes.
Okay.
Yes. We have them. Oh,
And does it move now or not?
yeah.
Yes.
Okay, good, because it's very strange. So it's a 48-year-old man with no past medical history. He didn't feel well in 2020, the beginning of 2020, and by the end of the year, he got a colonoscopy showing a non-obstructive tumor of the cecum. It was an adenocarcinoma with KRAS mutation. CT scan I'm going to show you shows bilobar liver metastases and the necrotic pancreatic lymph nodes, and these are the tumor markers CA158 and CA19-979. This is the CT. I'm going to go quickly through it. You see the metastases. Can you see the moving here?
Yes.
Okay. And then I'm going to show you a next slide, a summary of what's going on. So you can see the liver here. You can see both bilobar liver metastases here. I don't know if you can see my arrow, but moving here, but you can see a metastasis segment 1. And there's also segment 2 and 3 liver metastases, which are less involving than the rest of the liver. And there's a necrotic lymph node here, which is shown by the arrow, parapancreatic lymph node, which is definitely a tumor lymph node. And it was managed somewhere else. We didn't see the patient at that time. So he was considered to have unresectable liver metastases and a metastatic lymph node. So he was started on FOLFIRINOX and bevacizumab because his KRAS mutated, and he couldn't get any anti-EGFR. And he got 8 cycles, which were very well tolerated. His general condition improved on chemotherapy. The markers went back to normal, CA19-9, and the baseline is showed here. And there was an imaging response, and this is where he was referred for opinion here. So we saw the patient. He was an otherwise healthy man in good condition, 70 kilograms for 1.8 meters. No symptoms from the primary tumor, and I'm going to show you the imaging. So this is the MRI. You can see that the tumors have liquefied or hyalized, like you can see with bevacizumab. And I'm going to show you again a comparison of baseline and post-chemotherapy. And you see there's an objective response to chemotherapy, especially, but if we look closely at segments 2 and 3, you can see 4 small deposits, which are shown by the arrows here. Can you see?
Yes.
Okay. So we have the lymph node also, which responded to chemotherapy, and this is the primary tumor. And we did a PET scan. I didn't have the images, but everything was PET negative. So complete morphometabolic response. This is so at MDT we discussed the following, and I would like to have your opinion. It's been treated already. So continuous systemic chemotherapy, resection of primary intraarterial chemotherapy, 2-stage resection with interstage venous deprivation, which would be a resection of the tumors in the left in the segments 2, 3. Then followed by portal vein embolization, hepatic vein embolization, then extended right hepatectomy, ALPS procedure, and we also discussed the timing of colon surgery. So I'll let you discuss. Or maybe in the interest of time and discussion, I will show you what we did. Okay. So this is a reminder of the tumor status, and we opted for ALPS, and we, of course, and the liver first operation, and the timing of colon surgery would be later. So we brought the patient to the operating room. It was 6 months after the diagnosis. We found no fluid, no carcinomatosis. The liver looked normal despite chemotherapy. There were many mets in the right liver, segment 4 and 1. We were able to find 2 of the 4 lesions in the left lobe, in segments 2, 3, 2 subcapsular lesions, but there were 2 missing metastases despite intraoperative ultrasound. We could feel a firm parapancreatic lymph nodes. The other lymph nodes were unremarkable. And the cecal lesions were 5 centimeter mobile, no capsular retraction, and no apparent lymph nodes. So some comments here?
You did the right things.
I don't know, but because we're running out of time, and we're going to discuss what we should have done. Anyway, we did a complete lymphadenectomy, partial resections in segments 2 or 3, and we did a full ALPS, which is full transection, including segment 1, and ligation of middle hepatic vein. And this you may not find appropriate, Pierre. The right portal vein ligation, and this is the first operation. 2 resections in the left lobe here, segments 2, 3, full transection, and ligation of middle hepatic vein, and ligation and transection of the right portal vein. The pathologic report showed a complete response of all sites. The lymph node, the segments 2 and 3 lesions were complete regression. So day 6, we repeated the CT, and we found that the left lobe, the segments 2, 3 had increased from 366 to 588. And the mebrofenin scan showed that the left lobe had a 40% activity. So we went for second stage, and it was an easy operation because everything was prepared. And the path report showed complete response again. And this is the post-operative scan, 6 days, and you can see here that there's a small deposit that we were not able to find, and the patient was okay. So the question that I want to address here is, what would you have done something different?
Daniel?
Yes.
Of course, you will not be surprised that this is a very good strategy. But for me, there is an alternative I would have chosen, is to do exactly like you, the first stage, lymphadenectomy and clearance of the left lobe. But I wouldn't have done an ALPS, and I would have a RASP procedure just after the operation, and then 15 or 3 weeks later, I would have done the right hepatectomy and the colon in the same time. So the patient would have 2 operations, everything at 3 weeks.
We would do the extended right hepatectomy with segment 1 and colectomy at the same time, right?
I would have done the resection of the segment 1 in the first stage.
Okay, and
first stage, clearance of the left lobe, segment 1, and then the right hepatectomy extended to segment 4, which is a simple operation after the portal and the hepatic embolization, and the right colon at the same time.
Can you explain to everyone what your RASP strategy is? Because I'm not sure they're familiar with the acronym.
It is the simultaneous embolization of the portal vein and the hepatic vein, either the right hepatic vein or the right hepatic vein and the middle hepatic vein. So here I would have done both, the right and the middle, because I had to resect, all or a great part of the segment 4. But if I saw exactly, I think a part of the segment 4 could have been preserved. I think the segment 4B is good, and maybe the segment 4A also. So all your metastases were completely well, how can I say, there was no more tumor, so it was not necessary to be very rapid, because the tumor was already gone with chemotherapy.
Yeah, but that we didn't know. This we didn't know.
You knew it after your first operation. Yes,
I agree with
but
that.
it is impossible to know it. It's a very good response.
Okay, so, and I asked, so maybe Pierre wants to discuss this case as well, because, by the way, Laurence has published this RASP experience in Annals of Surgery this year. And I think that Pierre-Alain did an editorial, and I think that Pierre-Alain will discuss two things. Number one, ALPS versus venous deprivation, which I can understand this term better, and also partial ALPS versus full ALPS.
Daniel, you want, I think Jean-Robert and Pietro want to say something.
Okay, sure, go ahead. I'm sorry, I cannot see that. I cannot see that. Please go ahead. I'm sorry.
Very, very quickly, I would have done as Laurence, but I don't think I would have dared to do the colon at the same time.
Jean-Robert.
Very briefly, Laurence, I agree totally with you. Congrats to Daniel, because it's a wonderful case, but just a little difference with your position, Laurence. I do the colon resection with the left lobe and not with the extended right.
Jean-Robert, I do not agree, because imagine there is a problem, morbidity with the colon resection. Yes. Imagine that. It would jeopardize all the strategy. So for me, I never do the colon sigmoid or right colon resection on the first stage, because it is potentially dangerous.
Well, we try to show you our results. I think if you have a problem with the colon after an extended right, I think it's also a pity for the patient.
But it is not an extended right after embolization. It's
is there any emergency to remove the colon?
None.
No.
So the colon can wait.
Of course it's not, but it's better for the patient. He had not. The patient has
extensive cancer. It can withstand another operation.
The operation is not the difference.
You're right.
Let's move on. And any other, Pierre?
Yeah, I mean, just what I understand, Laurence, what you did here, what you suggest, will be to operate and surgically remove the tumor in the segment 2 and 3. Is that right?
Yeah.
And so, I mean, for me, that's when I mean, number one, I think we don't have the same level of evidence between the RASP, as mentioned also in the editorial, and the ALPS. The ALPS, with many cases, with the result, with long-term, with randomized controlled trial. There's a paper at the ESA from the Privot group, etc. Here we know plus minus what we do. In this case, we have the age, all the factor goes for what we know, and there is 60% recurrent disease, probably regardless what we do. The RASP at this stage, there is no randomized controlled trial. It's coming. I know there is one going on, but we have no results. Your paper, which was very good and provide a lot of data, but there was a few things that we could not interpret. For example, in the RASP, there was a much larger future remnant than the other group, etc. So there was some suggestion we don't know. Safety is also relatively unclear in this situation. And you go for surgery. When you go for surgery and clinic, for me, it would be impossible to resist to do a total or partial. That's another conversation. Transaction, you are here, just do it. And we know today, with the proof of anything else, that it will end up to a regeneration that nothing else can match, not even the hepatic vein total. Maybe if you combine segment 4 and all the hepatic vein, maybe that we don't know, but it's probably not safe. So for me, the RASP is still okay, can be done, but it's a research protocol. We are far from the experience of the ALPS. We don't know what we achieve, either oncologically, either for the risk of surgery. I can see the enthusiasm, particularly in France, for many, from going on this procedure. Maybe it's right. Maybe it's right. But right now, we are not at all at the same stage of experience of plugging the hepatic vein, the portal vein. All radiologists do differently. There's technical issue, probably problems. In your paper, you have near miss, but no other problems. There's problem of emboly and other problem with disembolization. I think we really need, before we have a serious conversation, the RCT. And when the RCT is available, but the RCT with portal vein is not with ALPS. So that's another thing. So for me, hepatic vein goes with portal vein, segment 4, or the RASP, but the ALPS is not in competition in this situation. You are here, you need to clean, you need to do everything, so you transect partially, and that's it, and that's done. You don't need to go radiology, do many other things, etc. For me, that's my view on this. And the colon, it's a complete different topic. I think is independent whether you do ALPS or whatever you do. And I also agree, here we should keep in peace what doesn't hurt. And just if you respond to chemo asymptomatic, we will not touch and take any risks for anything interstage or the before.
So one thing,
Daniel, Rodolfo Rossi want to speak.
Sure.
Rodolfo want to speak.
So let him speak. Rodolfo, put your mic on. Your mic is out. Rodolfo, microphone.
Do you listen? Do you listen to me?
Now we can hear you. Now.
Yes. Sorry, because I have problem with one of my microphones.
Yeah, big echo.
Because I have no audio from one of my computer. But now, you understand me good or what?
Like you're in the mood. You're on the move.
Wait. Terrible.
Next time, Rodolfo.
Okay. Next time, Rodolfo. Yeah.
Sorry.
So
Daniel, can I answer to Pierre?
Yeah, sure. But Rodolfo, please turn off your mic. Rodolfo.
I try to stop that.
Remove your microphone, Rodolfo. Okay. Laurence?
Yeah. I agree with Pierre. There is no randomized trial.
Wait. Rodolfo, please stop your microphone. Thank you, Rodolfo. Okay.
Just to say that I agree with Pierre that ALPS is now a very good option for this patient. Maybe I would have done it, but it will be very difficult to do randomized trial between venous privation and ALPS because in this patient, ALPS was a very good strategy because it was a young patient, but I think that ALPS is probably quite heavy in older patient, and it's a quite difficult surgery on the second procedure. But of course, I can say that the second, the two-stage procedure with the venous privation is quite simple. And we are going on doing that. We have no complications of the embolization of the hepatic veins.
We need to move on. Okay, so we have two options here.
Yeah.
And we discussed that. One thing is that when you have bilobar disease, the ALPS is, your proposal is probably better if you have only one lobe lesion. And it's not clear in your paper how many patients had bilobar disease, but whatever. I think it's very interesting and you're showing us that. But one thing I would like to mention is that if you do a complete transection, second stage is very easy. Second stage really takes one hour, I'm telling you, because it's very easy. I would like to continue with this case because we have the follow-up. So at 3 months, of course, we left metastases behind.
Okay, it's okay, Monday.
and we can find 5 liver metastases. And this is January 2021. And he went back to his previous hospital.
That's fine. That's fine because I'm on a meeting now. I'm on a meeting. That's fine.
Please stop your microphone, please. And so what you can see here is the liver metastases. So I'm just gonna, for the sake of time, let you know what happened. They put him back on chemotherapy, FOLFOX bevacizumab, and after 4 months he had stable disease, and he underwent right hemicolectomy and radiofrequency ablation at another hospital. We were in contact. I thought that anyway, this is what we have now. They have not treated all the metastases, but he had his colectomy now. He had 2 radiofrequency ablation, and there's 2 more to go. These were done during the colectomy, and the 2 others will be done post-op percutaneously, and to be continued. Okay. So
Daniel, just one sentence. Not in this case, you positive lymph node, but one of the topic which may come in the future, is ALPS as a bridge to, because you can save a lot of time. You have recurrent disease; they still respond to chemo. No extrahepatic disease. I would speculate that could be the best result of liver transplant in selective, hyper-selective cases.
I agree with you, and we addressed that. But and the question is whether this positive lymph node will be a final contraindication. But at the moment, we believe it is. So so thank you. I'm sorry it was a little quick, but now we have Catherine who has a case. Catherine, are you here?
Yes, I'm here. Yep.
Okay, are you ready for your presentation, please? I'm going to start.
Yes, I will try.
So you go and share your screen.
Let's see.
Daniel, just to know, do you listen to me right now?
Yes.
Perfect. Okay. I'm ready after.
So you want to comment? Go ahead, Rodolfo.
Okay. Perfect.
So you want to say something, Rodolfo?
Yes. No. Yes, I have my case if you want, but.
Okay, Catherine is on now, so.
Okay, perfect. After.
Can you see my screen?
Yes, put in a slideshow, please.
Is this better?
Yes.
Okay, so this is a 50-year-old female who was asymptomatic and only found an incidentally elevated CEA at 444 in March. She's a known diabetic and has myoma uteri with ovarian cyst. And they proceeded to do a PET CT and found multiple liver lesions to their surprise. And this is the myoma and the sigmoid lesion that was presented as a wall thickening, which I actually can't really identify here. But these are the lesions presented initially, which were unresectable. They were told to be unresectable. So the CEA at that time was 444, and the patient was started with FOLFOX, and when the RAS status came out as a wild type, cetuximab was added, and continued to have their CEA level that decreased over time, and they did a repeat scan that showed good response in the liver, and the one in the sigmoid was relatively the same, wall thickening with no obstruction and still no symptoms. So this time the patient came to our hospital and sought the consult. So looking at these images, now we see that the image, the lesions became smaller, decreased in size, and I think some of them have disappeared. So we are thinking about resectability. So these are the, I will do this, yeah. So this is the pre-treatment scan and post-treatment. Here on the other side, we see that the lesion has decreased in size. So patient continued to receive the FOLFOX and cetuximab until recently in June. This has come down to 60, very good response. PET-CT showed the same, no change in the sigmoid and interval decrease in size, but the FDG AVID lesions were more, up to 6.2. So this is the PET-CT. But I requested an MRI because I wasn't quite happy with the CT that came along with the PET. So we saw all these lesions, and I think it can be resected, but maybe leaving some lesions behind, especially here. My problem is in this area where the lesions are in contact with the portal and also the hepatic veins. So here there are a total of 15 lesions, which I have outlined here. In the interest of time, I'll just go quickly. They are here. These are the ones that are in contact with the vessels. The one in contact here with the portal. A lot of vessels around it. But there's a total of 15 lesions here.
But how many lesions do you have in segments 2 and 3?
There's only 2. I can only see 2 here. Segment 3, there's 1 lesion here, and then another one in segment 2. So these are the only 2 lesions that I see for segment 2 and 3. The rest are scattered between 4, 5, 6, 7, 8.
Laurence, you want to comment? Have you finished? Do you have a conclusion, Catherine?
Yeah, that's it. We haven't done anything. It's just that the lesions now, I'm concerned about the R0 resection, the vascular in contact.
Can you show again where you have issues with vascular R1 vascular?
Yeah.
The real problem is the metastasis of the segment 4 near the portal, the left portal vein, and the major risk is the biliary risk, because the biliary tract just for me, well, it's not invaded, but it's so close, so it will be possible to be R0 resection of these central metastases for me.
Yeah, but even on the segment 6 and 8 as well.
But 6 and 8 will go. The
well, it is right. It is a right hepatectomy, right? Right
extended right.
It has to be an extended right because
extended right, but the left portal vein and the left is difficult.
Yeah.
Yeah. Yeah, this one in particular. Yeah.
Yes.
So what would the others do?
Any other options?
How many in the left lateral?
2.
2. So you can do eventually a 2-step.
But the question is about the central image that you have in the middle here, with the lesion which is in contact with the left portal vein.
It will be an extended right. It will be an extended right.
Yeah,
looks like it.
We agree on that. Okay. So, Laurence?
Yeah.
Would you explore that patient, clean the left lateral, clean segments 2, 3, and see what you can do here, and then do a RASP?
No, I think that for me, this patient with the central metastasis close to the left hepatic portal vein is not resectable for me.
Okay.
The problem is the biliary tract.
Yes, exactly. That's why I said it's the biliary tract. So maybe I would upgrade the chemotherapy to arterial chemotherapy in order to shrink this metastasis. Because for the moment, it is not possible to do R0 resection. and it would be dangerous on the biliary tract, as Jean-Robert confirmed it.
Pietro,
Yeah, I might have missed something, but in fact, you can make the anatomy of the left biliary tract more favorable by a dissection opening the hilar plates. And I'm not sure also why then if you treat it like a Klaskin at the last step, you don't need to preserve the that part of the bile duct. So I would still.
everybody understands what he's saying?
Did you understand?
We heard. Whether we understood is a different story.
Right. I would need a pen for that. But in fact, having worked a lot on the anatomy of the left bile duct, you can display. I mean, let's see if I can mimic it. But when you, yes, this is the left bile duct when it's closed. But if you open the round ligament, the left bile duct does like that. And with that, I think you can resect it.
Okay, so that's interesting. Pierre,
Here I will totally agree with Laurence. I think it will be a mistake. I mean, for me, I speak, I'm not thinking it's a mistake to engage in any kind of surgery, the after resection problems. I think here you need smart oncologist and maybe a pump with a few DR. LIDAR, unfortunately, is not available now. But I would try to get another few millimeters of downstaging and then go. But at this stage, I think we should restrain for surgery.
Jean-Robert?
I agree with the strategy intra-arterial chemo. She responded to FOLFOX, so we can try intra-arterial chemo. And the problem with the response is, like said Mr. Professor Bismuth, is the response is, if I do like Pietro, mimicking, this is the biliary tract, and the response is like this every time. And this is
it's not every time. There's a theory here that some people say the tumor shrinks to where it started. So if the tumor started here and then grew to the bile duct, it will go back to its original place. If it started here and moved, then it will go back to the bile duct.
This is what I say. This is what I say. The tumor returns to the place of birth.
Voilà.
But we don't know what is the place of birth. When we have a tumor of 10 centimeters, we don't know where is the place of birth. Okay. So, Jean-Robert, I am not quite sure that I say what you said. I say we don't know. And sometimes we are surprised to see that the tumor go away from the vessel. We don't know.
The thing is that this lady, she received like over more than a year of chemotherapy, right, Catherine?
No. Just 3 months. Just 3 months since March.
I'm sorry.
Yeah.
Sorry.
Just 3 months.
I'm not concerned about toxicity. It's just that it's difficult to increase response beyond I'm afraid it has reached its maximal response. Maybe I'm wrong, and you should continue chemo. And probably intraarterial is a way to go.
Problem, we don't have intraarterial. No experience with intraarterial. We don't have pumps as well.
I have one question, Mr. Chairman. Catherine, is there an objective downstage of the lesion on the liver in size?
Yes.
Because in that case, why not consider two-step, a classic two-step, meaning resecting the primary, which is still in place in the sigmoid, clearing the left lobe, continue after that surgery, chemotherapy with a new protocol, and then dealing with the right liver?
Okay, that's an option.
That can be an option, but because the sigmoid is completely asymptomatic, so I don't. Personally, I was thinking that there's no reason to touch it, and
I know. This is
the on the left are easy.
I know, but this is the Anglo-Saxon way of thinking. But in my opinion, if you leave the tumor in place, once you stop the chemotherapy, it will reactivate again.
It's not only Anglo-Saxon, Gina. We also do the same. We also leave the colon for the last thing. In any case, but maybe, and this comes from Switzerland. Liver first place.
So there's objective response in the liver lesions with FOLFOX and cetuximab. We know that we need further chemo. Should we continue with the same regimen, or should we change the chemo drug?
What you can do is do a triplet, which would be FOLFIRINOX. But you already have used cetuximab, and FOLFOX with cetuximab is the best reported response.
Yeah, the best combination, yeah.
So, only 3 months, you can continue. She can still respond, and maybe we'll know where the tumor was born. If it was born on the bile duct, if it was born in the liver. And hopefully it will be born in the liver, and you will be able to do procedure.
So who would agree to remove the primary and the small lesions on the left, as what Gina has suggested?
Me?
I would. Who would go for chemotherapy? More chemo. Okay.
More chemo.
So that's okay. Now we have 20 minutes. We can go up to 4:30. So we have 2 more cases.
Thank you.
Jean-Robert, you don't mind being the last? Jean-Robert, ça t'embête pas de finir? Tu feras
no problem.
Donc on va Surendra Mathur, you have a case to present. Surendra, is he here?
Daniel, I have my case, my actualization of the case that I presented already.
I wanted to finish on follow-up.
Okay, perfect.
Okay. Surendra, are you here? Okay, so go ahead, Rodolfo. Go ahead.
Perfect. Okay. Share my screen. Do you see my screen?
Yes.
Okay. Just a little introduction about the case that I already presented 2 steps ago. It was about the patient, a young patient, 56 years, that in June 2020 had a right colon tumor that was impossible to resect at that moment due to the compromise, vascular compromise. He has at that moment 19 nodules on the liver, and so he started with chemotherapy during 3 months, and after 3 months he had a right hemicolectomy done without problem. At that time he got COVID without problem, without complication. That's a comment. And after that he continued with chemo, 2 months else, add to the 3 months of chemo that made before the hemicolectomy. So he had a good answer. That was this one was the MRI before chemo. So with the 19 lesion, the lesion are around all the liver, and especially have 4 on the segment 4 and overall on the right liver. So after chemo, the lesion was always in place, more little than before, of course, but the lesion of the segment 4 was always in place, and this one was the problematic one because it was in contact with the left portal vein. So we proposed at that moment to do these different options of surgery, and finally we propose we rule out the parenchyma sparing resection due to the quantity of the lesion and the location. We propose to do 4 options: 2 conserving segment 4 and 2 without conserving segment 4, and we decide finally to do an ALPS, thinking about the radicality and avoiding to drop out of the classic 2-time stage. So we made an partial ALPS. You see here the lesions on the segment 2, the lesion of the segment 1, and the superficial lesion of the segment 4. And there were 2 Ls, one in contact with the middle suprahepatic vein and with the left portal vein, as you show you on the MRI. This one, the resection, the segment 2, the resection of the segment 1, portal ligation, artery reparation. So, and we cut the liver partially, maybe 50%. One question for the comment after is when I made that, I decided to conserve the middle suprahepatic vein because I thought that if we cut the liver and we cut the medial suprahepatic vein, we will have more problem with the vascularization of the segment 4 and maybe more problem with the fistula. So even if you know that if we make a ligation of the middle suprahepatic vein, as Laurent commented in his paper, we will drive the growth to the segment 2 and 3. That in this case maybe is a problem, but because you leave the segment 4 without vascularization. So I wait for the comment after. So what happened about the surgery? After post-op first stage, segment 5, the patient was at home, but with biliary leak, a little 30 centimeter day that stopped spontaneously at day 10. So at day 10, we perform a new scan volumetry, and the liver growth almost 18%, as you see here. So was good, but the volume was almost 30%. So we decided to do a functional study, and we perform an scintigraphy using mevofemine. The IVA, so the IVA index, that is the IVA, this is the index that was reported for the Italian hospital in Argentina. So the index was 18.7%, and as you know, the post-op hepatectomy liver failed in patients with cutoff less than 15 is 18%, so we are above, and we are in condition to continue with the surgery the second time. And at the day 13 after first stage, we made the second stage. So you have here the surgery, cut it between segment 2 and 3 and 4, the biliary duct, right biliary duct, and this was the future liver remnant. And this was the lesion that was almost in contact with the left portal vein, that may be a problem of the future. But the patient, after surgery, had this evolution. I will share with you the evolution of these 2 parameters that all of you know are the 50-50 criteria that predict the probability to have the problem, morbidity and mortality after surgery. And if you take that the value of the 15% of the normal PT correspond to ENR of 1.7, and the suero bilirubin of 50 micromoles correspond to value of 3 milligrams deciliter, that is what we use in Argentina. Our patient at the 5 day have 1 parameter inside of the 50-50 criteria on postoperative day 5, and 1 parameter ENR out of the criteria. So I think it's an alarm, but I don't know which is exactly the prognostic of this difference of the both parameters. So the bilirubin rise till the day 11, and that's worry me because I don't know what happened. Because what happened that the ascites start to appear at that time, but as you see here, the ENR continue normal all the time. So we thought that maybe that was due to the problem of the two problems. One is that the hepatocytes grow in a different time of the biliary tract grow, and the hepatocytes have the problem to release the bilirubin. And if you see here, the bilirubin was predominant direct bilirubin. We have a biliary total of 5.96 and almost 4.3 was direct bilirubin. So the other parameter was completely normal, no encephalopathy, the patient was eating without problem, so inactivity with a little of ascites that start to reduce around the days. So the PT, of course, was normal as the ENR, as you can see here, the day 5, and continue rising and normalizing days following. So, but just to rule out the problem with the biliary tract, we perform the day 9 MRI, and I show you here the liver, the volume, and we find some of ascites, as you see here, and around the spleen, but no biliary dilatation. I show you here. The liver without biliary dilatation. And so we have ascites but no biliary dilatation. And here on the images with contrast, we have a good inflow and outflow. You can see here the biliary bifurcation without problem. Here I thought that maybe we have problem, and was the reason because the bilirubin rise. And here we have the same, the axial cut. So about the transaminase start to descend after the second day post-op and normalize at the day 11, 18. The alkaline phosphates grow from the segments from the day 7, as is reported on the paper, maybe due to the liver regeneration. So the patient continued good, but the day 13 was discharged, but 2 days after got COVID from his daughter that cared him at the hospital. The day 18, 5 days after return to the hospital due to the fever without pneumonia, we rule out the problem. We found ascites, as I showed you, as the day 5, no other finding, and was discharged after 5 days. The day 13, he returned to the hospital due to the fever again and dyspnea, and we performed all of these excellent blood tests, blood and urine culture, and new images. The white blood cell was normal, the dimeral test was elevated as in COVID, and urine and blood culture was negative. I showed you the scan of the thorax. And you see some atelectasis here, right here.
Rodolfo, we need to move on.
And a fusion, and yes, and this other lesion in context of COVID. So yes, and the problem was that maybe the fever. The fever was due to the collection, to the abdominal, to the collection, to the ascites, maybe contaminating, and we perform a drainage of that. I'm sorry, but
Rodolfo, can you move on, please?
Sorry. Yes, I have a problem with the. Let me few minutes. I try to.
Because we have 2 more cases to go.
Yes. So finally, we drainage the collection of the that was some of ascites, some of bile, and the sulfenic, right sulfenic position. And the patient was okay, but the fever it was not for this collection because this collection was negative on the culture, and the fever was interpreted from the infectology due to the COVID. And finally, the patient come back at home without problem. So I wait for your comments.
Comments from the floor?
Did you do a liver biopsy?
No. No, but I think that that is interesting to comment is that if this dissociation between the evolution of the patient and the level of the bilirubin after the surgery, if it was that was because of the regeneration that I think was for that. Because we rule out the obstruction or we rule out other problems to have this elevation of the bilirubin. And by the way, there are many papers, even one from René, that spoke about that when the liver make a regeneration after 1 week. I don't know which is your opinion about that, Pierre Alain, with your experience with Alps and others from the audience.
Well, one thing that we know is that regeneration takes time, especially if the liver has received chemotherapy. So that's why I asked you about liver biopsy, pre and per-op, because to have bilirubin increasing, it's not unusual. That's my comment.
Yes, I took your comment. I think that this is one option because this patient have oxaliplatin and bevacizumab, and you know that the bevacizumab have some protection over the oxaliplatin, and that was the driver from the people from Suiza.
One thing I have experienced, and I don't know about the others, is a special form of post-hepatectomy liver failure, which is marked with normal coagulation and high bilirubin. And if the bilirubin remains high for several weeks, usually it's not very good news, in my experience. And you don't have biliary obstruction, you have nothing. But sometimes, like your case, it went down again. So if it goes down, she's going to be okay. And you have, of course, to make sure that there's no abscess, no fluid collection, no nothing. And she had COVID in addition, so she's going to be okay, I think. We need to move on to the next presentation. Surendra?
Yeah.
Thank you so much.
Let's share the... Am I able to share it? Is it seen?
Press the button share. You have to share.
Yeah.
In the lower part of your screen, you can see the red telephone.
Okay.
So it's two to the left of the left telephone.
Daniel, just a question. What do you think about my comment to make a ligation of the medial suprahepatic vein when you make an Alps cutting between segment 2, 3, and 4? So with the problem of the desvascularization of segment 4, because you do that, you did that as your surgery, but I
did that because I was doing an extended right, and you did
yes, me
don't care about the middle hepatic vein.
But at the first stage, so.
Yeah, I did that at the first thing. That's what we do because we want to challenge. We want to get maximal growth from the left.
Yes, I know. But what about the vascularization of segment 4 between first time and second time? Because
because I do complete ALPS, I devascularize completely segment 4.
Just a minute, I think there's some problem. Let me just sort it out.
So I'm back. We don't see.
Yeah, I'm just trying. It should be a window or whole entire screen.
Did you find the right button? It's.
Yeah, I've opened my presentation and then
No, you open the presentation, but we can't see it. We don't see it.
Yeah.
Ouais, Maurice, je suis
Okay. Then now let me see if the entire screen.
Non, mais j'ai vu ton message. Passe-toi donc avant, hein. C'est ça? Parfait, génial, à tout.
C'est bon, Jean-Robert, je peux venir aussi?
See it or no?
Bon, moi si vous voulez, je peux présenter, Daniel.
Surendra.
Yeah, we'll wait. You can go ahead with the next one.
Okay. So should we try again, Surendra? What should we do?
There's something.
Okay.
No, there's some problem with my computer. It is creating some problem.
Okay,
so go ahead with the next.
Save it for next time, please.
Yeah, sure.
Okay, Jean-Robert, you can have the last case.
Okay, I try to share the screen. Do you see my screen?
Yes, we can. We do see it.
So, just a minute.
Mais à la fin, comme ça, on a tout vu.
Bah ouais, c'est ça, oui. So, this is a case from a surgeon.
Mets-toi en diaporama, comme ça on a la full screen.
Alors, diaporama.
Slideshow. No.
It's okay?
Ouais, super.
This case is a surgeon sent to me this case after a webinar I do 15 days ago about pancreatic cancer, but it's not a pancreatic cancer. The story is a 35 years old female patient known for a long time for chronic pancreatitis of alcoholic origin. She smokes and she's addicted to opioid drug, but the addiction was weaned. In May, she was hospitalized for severe and worsening abdominal pain, normal blood count, CRP 12, alkaline phosphatase 800, no cytolysis, albumin showed denutrition with 25 grams per liter. During 21 days, the patient was hospitalized with a recurrence of intense epigastric pain, requiring very high doses of morphine, stop feeding and dehydration, so total parenteral nutrition, no bowel movements since 1 week, and onset of jaundice. These are the CT findings. The surgeon said to me only the CT. I have no MRI and no coronal view, but I think that the CT is enough. So this is the first slide. We show a left hepatic artery coming from the gastric artery. Okay. This is the celiac trunk, the SMA. You can see here the right hepatic artery coming from the SMA. And this is, I do a reconstruction for you. This is the portal vein with the dilatation of the bile duct. And you can see here the collateral vein, the huge collateral vein here, the splenic vein, and this is the splenic hilum. This is the left pancreas with calcifications, a dilatation of the main pancreatic duct. This is the portal vein, and this is the biliary convergence here. Portal vein again, left renal vein, SMA. This is the SMV complete stenosis. This is the portal vein, the splenic vein, and here is the portal vein, the mesenterico-portal vein stenosis. Here again, you can see here the left pancreas with the main duct. Okay, and as you can see here, a huge inflammatory mass in the pancreas. Here, this is the gallbladder. Okay, this is the portal vein here. So we have an inflammatory mass in the head of the pancreas, a stenosis of the confluence of splenic and mesenteric portal vein, and a huge collaterality. This is an overview with the main pancreatic duct. The gallbladder is here. Stones in the main duct here. Another here. And a duodenal stenosis. You can see here the duodenum. Here, here, and here. Completely obstructed by the mass here with calcification, multiple cysts, and stones. This is another view with a huge cyst here and the stenosis of the portal system. Another view here with the complete delamination, compression of the third duodenum here. This is the gallbladder once again. This is a huge cyst with multiple calcifications, multiple vein, collateral veins here, here, here. This is the ileocholic branch. You can see here. The inferior mesenteric vein here, and this is a view of the mesentery with multiple jejunal veins. Summary: diffuse pancreatic stones, dilatation of the main pancreatic duct, multiple cysts with necrosis, dilatation of the gallbladder and intrahepatic bile ducts, stenosis of the duodenum with thickening of the duodenum wall and submucosa edema, stenosis of the portal SMV, SV with multiple collaterals. Arterial phase, in summary, this is the left hepatic artery coming from the left gastric artery here. Hepatic artery from the SMA here. And this is the inferior pancreaticoduodenal artery. You show very well here with a huge cyst here. And again, the gallbladder here. This is an overview of the duodenal stenosis at the arterial phase. This is the duodenum. Once again, here. Again, this is the duodenum. Here, here. And the huge mass in the pancreatic head with multiple stones and cysts. And finally, this is a nice view of the duodenum and the third duodenum here with multiple cysts and the gallbladder here. So, The surgeon take a decision in June very recently. He does a gastrojejunal bypass without significant difficulty, a cholecystojejunal anastomosis, and the argument was, I want to avoid the dissection of the hepatic pedicle in case of a secondary pancreaticoduodenectomy. The postoperative course was uneventful with a pain relief, with withdrawal of opioids, and the nasogastric tube gives 2 liters by day with reinstillation in the jejunostomy, and the enteral nutrition was well tolerated. And he said he sent the case to me and says, and now what we do? So I'm waiting for your comment because I think it's quite difficult, and then I do rapidly the discussion.
Did he do an OGD?
No, he does. He does gastrojejunal bypass, cholecystojejunal anastomosis, and postoperative course, pain relief, and enteral nutrition.
No, before the operation. Est-ce qu'il a fait une fibro endoscopy?
Yes, why?
Just to see, did he have varices or anything?
Yes, there is varices in the stomach.
Okay.
Small varices in the stomach, but when you look to the CT, there are multiple collaterals.
There was no stone in the gallbladder.
No stone in the gallbladder.
C'est le bon moment pour dire que tu es parti à la retraite, Jean-Robert.
Exactement ça.
Oui, Jean-Robert, est-ce qu'elle s'est améliorée? Did she improve with surgery?
Oui, yes.
That's very important.
And it's incredible, but the patient is well with
asymptomatic.
No asymptomatic, because there is the
pain.
2 liters by day with with the reinstillation, the jejunostomy, enteral nutrition, etc. And the duodenal stenosis is always in place. So we have portal problem.
Robert,
oui.
You said you did gastro.
I understand. No.
You said you did the gastrojejunal bypass.
Not him. The other hospital.
Not me.
Yeah. The problem is that they have an external biliary drainage now. I mean, the stomach is in circuit with you have output of digestive, if I understand all right, of the bile is going out.
Non, même pas. Même pas.
So, Jean-Robert?
They did do a complete bypass, and there is no internal re-uptake of the biliary derivation, if I understand all right.
So what do you propose, Jean-Robert?
Well, I wanted, Jean-Robert, I remember in the past, several years ago, and I can say many years ago, we did a few, a few Whipples, a few pancreaticoduodenectomies for chronic pancreatitis, chronic pancreatitis, right? And of course, it may seem impossible here, but
I think so.
Yeah, no, but if I may share, it's only one person that can share at a time. I just want to show you a picture that I just, I don't know if you can see it. Can you see the picture?
Alors attends, je vais pousser ça. Yes, I see the picture.
So this is not the same case, but this was a patient with a huge neuroendocrine tumor of the pancreas, and with a complete portal vein obstruction. And we started doing a bypass between the superior mesenteric vein to the portal vein to relieve portal hypertension. Then we removed the tumor, and then we did a direct reconstruction of the portal vein.
Okay. So May I go to the discussion? My proposition?
So,
I begin by the end. I begin by the end of the discussion here.
Jean-Robert,
Is
can
there
I
a
ask you a
place
question?
for? Yes.
I don't think we all understood the problem, because you said there is a cholecystogenital bypass.
Yes.
So, and there is a gastrojejunal bypass.
Yes.
So, what is not taken up? Because from what you show, it would seem as if everything is internalized into the jejunum. So what is not internalized?
Yes, but I think it's not enough for the patient. I think it's not enough because she's 35 years old. And we have to do something better, probably.
Yes, it's true.
And I go to the picture of Daniel here. We have, my first question is there is a place for a shunt in case of resection? This is my first question. And we have literature and a recent paper of the Heidelberg team. It's for pancreatic cancer, but it's the same problem. Another case recently published with a huge endocrine tumor.
Jean-Robert, on voit plus ta présentation.
Ah mince, alors attends.
C'est ma faute. Retourne.
Comment je fais?
Tu reprends la main. Moi, je suis sorti. Tu reprends la main.
Alors, arrêtez le partage. Reprendre la présentation.
Reprendre la présentation. Voilà, ça y est, on t'a à nouveau.
Jean-Robert, you want that we discuss about the treatment of the portal hypertension in this case before doing the surgery. And Daniel proposed to put this graft, the temporary graft, but also we may do a stent.
Alors,
for there is no invasion. There is no invasion. It is a chronic pancreatitis, so you have no invasion, and you may dilate the stricture and put a stent just before the operation. Then you do the operation, and really in half a day, a few hours, the portal hypertension disappears, and you may do the normal operation. That means the Whipple operation normally. Then the question is what to do for the vein. You may at that time try to remove the stent and to see what happens. If when you dissect by removing the pancreas, the vein, you open the vein. You don't need to let the stent.
Yes. Thank you very much, because it was two parts of my discussion. The first part is there is a place for a portal stenting? This is my first question. And I think you do an answer. This is the first part. The second question is there is a place for a shunt in case of resection? And I think yes, like showed Daniel, it's possible to do a shunt during the resection if we do a resection. But my concern is
Mets-toi en diaporama, s'il te plaît. Parfait, merci.
My concern is probably pancreaticoduodenectomy with stenting of the portal vein, with shunt, grafting shunt, is perhaps not the best way to treat the patient. We agree that the patient should be reoperated. If you look to the consensus conference, very recent consensus conference, they advocated surgery when there is an involvement of adjacent structure, duodenal, bile duct stenosis, portal hypertension, etc. So, no percutaneous drainage, okay. And the problem is what kind of surgery? In the literature, I found only 3 case reports with such a situation. And the best seems to me the recent report published here. They do a trip digestive tract reconstruction in a chronic pancreatitis complicated with bile duct stenosis, duodenal stenosis, and portal vein stenosis. You can see here the image is quite the same patient. This is the reconstruction. And they do large. You hear me?
Yes, yes.
Yes. So they do, to avoid the intraoperative bleeding caused by the collateral, etc., they choose to do a large drainage of the pancreas, partial resection of the pancreatic head, and, as you can see here, hepaticojejunostomy, gastrojejunostomy, and Brown's anastomosis. That seems to me an omega here. I don't know if they are right, but if you look to the post-operative course, they have no post-operative complication. The patient was discharged from the hospital at day 14, and they follow the patient for 5 years after surgery without abdominal pain or recurrent pancreatitis. So perhaps this should be an option. But I want to advise because I don't know.
Jean-Robert, what do you mean by partial resection via the pancreas?
Well, it's like
Heidelberg technique.
Yes, it's like frais procedure.
It's creuser dans le pancréas.
Yes, yes.
But there's one thing I think is that it looks like there's a pseudo-inflammatory mass of the head of the pancreas.
Yes.
And I think this is a rare case of, because if it's a ductal dilatation and stones, then this can work. But if it's a pseudo-tumor of the head of the pancreas, this is where the pain is, and I'm afraid it will not be cured. Because this is not distal pain, this is pancreatic head pain. And I think that the only way to cure her, whether it's reasonable or not, is to be discussed, is Whipple.
So, what is your proposal? First, stenting the portal vein?
I think, if I may, I think that stenting is good. The thing, if you do it during the operation, the bypass is good because you do the bypass, then you remove and you can remove the portal vein with it.
Yes.
Because if you put a stent and you have to remove the portal vein, you remove the stent with your specimen. And then the portal hypertension is again here. With this temporary shunt, you can keep it as long as you want. You remove the head of the pancreas and the portal vein, and then you can reconstruct the portal vein.
So this was my first opinion, to do a resection with a bypass. Do you agree with this?
This is what Daniel proposed that. But the bypass, you remove it or you
Yeah, you remove it. You
remove it.
Temporary bypass.
The proposal I did for the stent is to put the stent, a silicone stent, and then you may let the stent. I mean, you don't remove the portal. You dissect the pancreas, keeping the vein, all the vein. And then you after, and you may remove it. So the stent is or the temporary or definitive.
There's too much inflammation. Too much inflammation to keep the portal vein.
No, but the inflammation will disappear after the Whipple.
No, but this is during the surgery. You need. No. Listen, please. Maybe you're right, but another option is that when you do the Whipple, you cannot keep the portal vein because the portal vein.
Why you cannot keep it?
because in a chronic pancreatitis, it's stuck to the vein.
No. Jean-Robert may answer for that. You may say it's not necessary to
you don't know in advance.
To be at the contact of the vein. You may let a small part of the pancreas. It's not important. It's benign disease, so you avoid to touch the vein. What is doing Marcus? Robert? You seem to be totally annihilated.
No, I'm not annihilated. I try to answer, and I think it's a very difficult case. And pancreaticoduodenectomy is a risky procedure. I think the only way to do if we do a pancreaticoduodenectomy, I think we must put a graft for shunting. I think it's a good idea, but I don't know if it works.
Can I comment, Daniel?
Sure.
Every comment is it's welcome.
Yeah. Okay. Let's see. We do see such cases. Number one. Now, here's what is the problem? Is definitely chronic pancreatitis with inflammatory head mass, which is causing compression of the biliary tree, causing compression of the portal confluence with the SMV and the splenic vein, and causing the duodenal compression. Most of the time, these are compression, not infiltration. Unless the chronic pancreatitis, that head mass has turned into a malignancy. So, what can be offered if there are no telltale signs of malignancies? In that case, is whether you do the Fry's procedure or Beger's. There are two options in which you will preserve the duodenum. As you pour out the head mass or you resect, you will realize whether duodenum is opened or not. Okay. If it is a segmental thing, one can do the segmental resection of that part of the duodenum, but it's usually third part duodenum which gets compressed. And once you do that, you will realize sometimes the biliary obstruction also goes away. If it doesn't go away, then what was shown, what you were showing the diagram, that is you are doing a lateral pancreaticogynostomy and covering that area where you have removed the head or the cored out area. Okay, the coring versus bigger resection will depend on whether you have got a high intuition for any underlying malignancy or not. And then you just do the bypass, and then see, this will relieve the pain. So that's going to give the long-term result. Just what has been done is the bypass, triple bypass, which we do for malignancy, is not the answer for this patient. Now, how do you deal with the portal compression? Most of the time, once you do the Beger procedure, portal compression should go away. Now, yes, if you find that there are too many dilated collaterals around that area to do even the safe coring, then what Daniel is saying is right. You create a temporary shunt between the SMV and the portal vein on top, and that will collapse the thing. You finish your surgery and you can reconstruct the SMV portal vein and splenic vein junction. Either using a graft or if they can come together if the gap is not much. I think that will be the approach for me.
Can I say something?
Can I show more pictures? Go ahead.
Okay. Jean-Robert, two things. So I see that you have inflammatory mass. This mass, I don't see it like huge. This patient has a portal hypertension, but unfortunately they've already done a sort of double bypass, although the biliary bypass is not optimum. So you have two choices. Either you go, as you said, for a radical resection, like doing a Whipple with shunt and everything. Otherwise, you deal with what you have now. So this patient has a portal hypertension caused by compression. So either you can go for a portal vein stenting to dilate and to decrease the portal hypertension, she has already a gastrojejunal bypass. I do not agree with this cholecystogeginostomy, which doesn't work. So you have to do a proper hepaticojejunostomy, a biliary bypass. So either you want to bypass a possible portal hypertension by doing intrahepatic jejunostomy, or either you do decompression of the portal hypertension and you do a proper hepaticojejunostomy. I'm not sure, because you said that after this operation, the patient does not have pain anymore. So I'm not sure that the mass is causing the pain currently. So I would optimize the double bypass by doing a proper hepaticojejunostomy by two ways, either by doing decompression of the portal hypertension and do a hepaticojejunostomy, or bypass it and do an intrahepatic jejunostomy on segment 3. This is my proposal.
My take on it is that there's space for only one more operation. You're not going to operate twice in this patient.
I agree.
And I don't know if I'm right, because I remember it's been a long time since I've done a Whipple in chronic pancreatitis, but I was doing a few with my former boss, Pierre-Louis Fanier, who had patients like that. And what I remember is that those patients were really, the pain disappeared. It's only in one situation, which is the large mass of the head of the pancreas, which is the case here, which is causing the pain. If I can show you again some pictures, I don't know if you're interested, but I think it can be interesting.
J'enlève ma présentation, Daniel.
Yeah, Pietro, what do you think, Pietro?
I'm listening, because I'm here with the expert in the world of this kind of stuff. And Daniel and you don't have nothing to say but to listen.
Okay. But what you don't know is that I have experience with chronic pancreatitis from the past.
Yes, I do. You told me. So that's one of the other persons I'm listening to.
Okay, I thought you were telling me shut up. But
no. On the contrary.
No, this is just I don't know if can you see that?
Il faut que j'enlève, Daniel, il faut que j'enlève la mienne là.
Je sais pas.
Non, mais c'est bon.
Je vois pas tes images.
Mais toi, tu me vois peut-être pas, Jean-Robert.
Je te vois pas du tout là.
Non, moi je vois tout très bien.
Tu la remettras assez facilement.
Arrêtez de partager.
I just want to show the concept of the temporary bypass, if I may. So it happens that I just did this video last year, and so this is the bypass after resection. So the resection is done. This is a cryopreserved vein, and I'm going to go fast. And we put the vein here, and then we remove the bypass.
Yeah.
This vein above, then we remove the bypass, and this gives you a full portal vein reconstruction. And then you remove the portal vein, and this is the final result. Okay. And this is what you can do with the temporary bypass. This is just what I wanted to show you. It works. The question is whether the Whipple is feasible. But I think that with portal decompression, you will be able to do it. And the pancreatic anastomosis will not be a problem in this patient. And I think that you may relieve her. Of course, this is not a zero mortality operation. I would say it's a 5-10% mortality. But of course, you're the one who has seen the patient. I'm stopping my presentation now.
Daniel, this case is a cancer.
Yes, it's true. It's true.
No, what I said is in chronic pancreatitis, you don't need to remove the vein.
It's not a question of needing. It's a question that you cannot do it differently.
I know, but what I propose the stent. In order to let the stent is not necessary to resect.
I understand, but
this is different.
No, it's not option. What I'm saying, Monsieur, is that what you're saying is the best if you can keep the portal vein. But if during the operation you have any injury to the portal vein or anything, you have to do something. Here, you're protected because you have a temporary bypass. That's all I want to say.
This was my first opinion. When the surgeon sent me the case, I said to him, probably if we have to do a resection, we must put a shunt to protect the blood from the vein, the injury of the vein, etc. My only question is there an alternative to the Whipple? This is my only question. Is there an alternative to the Whipple?
If you listen to the pancreatologist, no, it's a specialty. If you listen to Beaujon Hospital, for example, where they say that pain always disappears with time and there's no indication for surgery. That's what they say.
It's not, well, not the experience I have, in fact, of seeing, certainly not as many of those patients. I see them with great, endless misery until they get the surgery.
So this is what...
Yes, but not necessarily resection.
Can you show us again, Jean-Robert? Can you go back to your presentation, please?
Yes.
And show us the images of the big mass of the head of the pancreas.
I don't think...
You see my screen here?
Yes.
Other than resection here.
Voila, here. I'm sorry, but it's going to be a big operation. Maybe I would be afraid. Well, by the way, you need better imaging with a coronal view. Reconstruction, vascular. This.
The problem, if you look to the portal vein, I don't know if the stent is possible, because here is the stenosis here, and the venous axis totally disappears in the inflammatory mass.
Really?
This is normal, this is normal. But, it is only a external compression. And the radiologist who can know how to open the vein.
Well,
the problem with the stent will be that if it is going across the splenic vein, because this obstruction is at the junction of the splenic vein, superior mesenteric vein, and portal vein.
Yes.
A stent which passes through will block the splenic vein. That means there will be left-sided portal hypertension. That means the collaterals in the pancreatic bed will increase further, because there is no drainage to the splenic vein then. The spleen will go up. So the stent is not the answer in this situation, because unless this would have been malignancy, then yes, you don't want to do anything further. But this is a benign young patient. We have to give the relief to the pain. Zina, I don't agree with you that when there's inflammatory head mass, there's enough work which has come from Heidelberg. Okay, and Helmut Friedrich has published a lot of papers on that the pacemaker of that pain is in the head, and you have to deal with. That's why the Beger's group, they prefer the resection of the head, duodenal preserving, while the Fries, he believed that even if you decompress by removing most of the inflammatory tissue and de-roofing most of the ducts in that area, okay, it gives the relief to the pain. So that is what is required. You have to deal with that inflammatory head mass and then provide the drainage to everything, because pancreatic duct is dilated throughout the body. Okay, there are not multiple strictures, so you don't have to open it like a lateral pancreatic ostomy. Even the end anastomosis will work. And on the table, one has to decide whether the biliary decompression has been achieved or not. If not, then bilioenteric anastomosis has to be done. If a resection is done, definitely bilioenteric anastomosis has to be done. And that junction, if it doesn't open after doing all this, you have to reset what Daniel has shown and reconstruct that.
Okay, my friends, it's 4:35. And
Daniel, what I said to the surgeon, I said, send the patient in Polmos.
no, keep the patient in Marseille.
You know, Robert, the staff is only consultation. You take the decision.
Oh, yes.
Okay, my friend.
This is good for us. This
Let
is
us know.
Daniel, okay, thank you, Daniel. You organized very well the staff, and it was a very nice presentation. Thank you. I would like to thank, this is the last staff of, let us say, of this year. I would like to thank Marcelo and his colleague Daniel, who organized so well his staff. I said this is the last one of the year. We will continue at the end of September, but in October, we have no staff. The reason is that we have the meeting the first week of November in Vargo. I think Christophe is here, I don't know, but I will tell you something. We decided with Christophe to organize the meeting in Vargo. Of course, it will change, but we go to organize it.
Absolutely, sir. We are going to organize in person.
In person, okay. We start by organizing like this. Of course, some not coming, we will do a part hybrid, that means presentiel and virtual. For the presentiel, I have two things to tell you. One is that you need to have this. Yes.
Would you like to show you mine?
Yes. That means that this, in French, we
COVID.
Since 2 days, it is European.
Yeah.
That means we may circulate in Europe. First is this. The second point, which is very important. The majority of the company today sell the tickets, the flight ticket, and reimburse in case we cannot travel. That means I recommend you to take the ticket now and be sure that the company reimburse. Air France, when I ask Air France, they will reimburse fully and immediately if the flight if we cannot go there. So this is the two precautions that we may have. And then, of course, we hope to have the meeting, but in case the last week it is impossible, we will do it anyway, we will do it, but totally virtual as we are doing virtual. So Christophe will organize the two possibilities, and we do the meeting. We go to have the meeting, and I hope that we will be there in presence all together. And personally, I will love to see and to meet all of you and to have an excellent dinner, a banquet with all the compagnons and all the new compagnons. We will have the new compagnons to come. But
Christophe, my ticket was bought in 2020.
The last point I said, and we discussed, the last point is that you may start to prepare your presentation. There will be, as usually, 1 day of clinical case. That means the one we organize will be the first day of the meeting. And I think 2 days, but it depends. For this, I don't know. If it is virtual, it will be 1 day.
Yes, we'll follow this pattern as usual. So the hybrid or in-person meeting, we are in the course of preparation. So strongly believe that I will have the pleasure to hosting you in Warsaw, and let's hope it will happen.
Christophe, we don't see you. We don't see you. Where are you?
You know, I'm at home.
But we don't see your figure. You are.
No, I'm here.
No, we don't see your image.
Si.
Okay. Okay.
Ah, on le voit, monsieur. On le voit très
bien. Yes, sir.
Now we see you.
Thank you once again. Please prepare your time to visit Warsaw, and we'll do our best to be wonderful hosts at our city.
Christoph, what's the date again? The date.
Good question.
The dates are exactly from the 3rd until 6th November. It means that on 4th November, that's Thursday, will be the case meeting, case stuff. Then on Friday and on Saturday, entire or half a day, it will be the symposium, followed by compagnon dîner.
That means that we will leave Sunday Warsaw and we will arrive in the evening of Wednesday.
I think that's the best option.
It's the best option.
Otherwise, you are invited to follow your visit to Warsaw, to visit the southern part of Poland of Auschwitz, or northern part,
yes,
the Solidarity movement in Gdańsk. That all those informations are put on our website, which from Monday we'll have a new title when the figure 2020 will be changed to 2021. Compagnon HPB Warsaw dot 2021. Okay, so yes. Please, I will mail to all the companions the new website address in order to pass all the recent informations from scientific program and social one.
Thank you, Christophe. So I will speak with you in order to send a common mail to all the compagnons in the following 2 weeks. Okay, absolutely. This is our now we will be in vacation.
Okay, everybody.
Okay. Adios, los amigos.
Bon vacances.
Bonnes vacances.
See you.
Bonnes vacances. Adios.
See you. Bye bye.